So this is our map of the world. This map actually isn't in Australia. It's actually in London, outside of the London School of Economics, where my son is a student. And but I just thought I'd show you the way we think about things. Now, just picking up a theme that Tom mentioned, the fact that diagnosis, and I think he might have added to this, was probably not working that well for us, and it definitely needs a newer approach. This is a polemic, actually, written by an American who really was very anti-psychiatry in general, but it did make some interesting points. And Tom also mentioned Kraepelin. I'm not such a big fan of Kraepelin because he actually introduced things which weren't really right into psychiatry, that the fact that you couldn't get better from schizophrenia, for example. And I think that he's really frozen our diagnostic system for over 100 years, and we're trying to unfreeze it. That's what I'm going to be talking about. And of course, we've got to deal with the boundaries. Mario was saying the early stages are very fluid, and it's difficult to work out exactly when a need for care begins. But it certainly begins long before you attract diagnoses like schizophrenia. So we have to actually map that territory much more effectively. One of the great thinkers and writers on this topic was Robert Kendall, an English psychiatrist who just worked out what diagnosis was about, really. And it's really about three sets of characteristics, some that are unique to the individual, some that they share with other people, and some that share with some other people but not others. And it's only the third group of characteristics that really help you in classification or in diagnosis. But diagnosis is really about deciding on what sort of treatment you want to use. That's the main purpose of it in medicine. That's the main reason we as doctors believe in diagnosis, actually. Prediction is all very well, but treatment selection is the main purpose, and as Tom said, it hasn't really worked that well for us in terms of selecting treatment. Our treatments are very non-specific and transdiagnostic, most of them. And so Jim Van Os and I, a few years ago, tried to think about this a little bit more deeply. How could we, this was at the height of the storm of DSM-5, and how do we make diagnosis respectable and workable? And give it a better name than it actually does have in psychiatry. As Mario alluded to, we began this work in the early 1990s by looking at the early stages of psychosis. And we tried to prospectively operationalize a mental state which indicated risk for progression to a first episode of psychosis. Not schizophrenia, but first episode of psychosis. And, we were motivated to do that because first episode patients that we saw in our new clinic at EPIC had clearly had a long period of struggling in various ways before they really reached the stage of being diagnosable with a psychotic episode. And it wasn't just untreated psychosis, it was a more subtle earlier stage, which actually Kraepelin described, and so did many other people retrospectively. But prospectively, could you operationalize it? We were able to do that, and that led to a quarter of a century of studies, including 15 randomized trials of treatment in this stage of illness. The initial transition figures were about 30 or 40% over the first several years, maybe up to 3 years. But then more recently, the transition rates have dropped a lot, to between about 10 and 20% for reasons which are not totally clear, but certainly it's not as strongly predictive of only psychosis as it used to be. And this has been paralleled by a series of critiques in the journals about this concept. It's been a controversial, contested concept, which you don't actually see in pre-diabetes or other areas of medicine. There's a paper in the New England Journal recently which showed that you could delay the onset of insulin-dependent diabetes by about a year or so. And this was headline news, incredibly valuable breakthrough. In psychiatry, we've been able to do that for at least 10 years, to delay the onset of first episode psychosis through cognitive behavioral and other sort of psychosocial interventions. But that's almost resented by some people in our field, and certainly disputed. So this is interesting, why this should be so controversial. Anyway, this is a series of recent critiques Very interesting one just appeared from Peter Jones, which actually is much more in sympathy with what I'm going to talk about, this transdiagnostic approach. And it's making the point that the non-specificity, you know, the fact that the transition to psychosis is a significant, at a significant level, let's say it's 20% at the moment. That's much higher than the general population, certainly, and much higher than primary care populations. But there are other syndromes that there is transition to as well, or at least comorbidity with. So it's still a very, shall we say, pluripotential sort of risk state. It also indicates risk for other things like suicidal behaviour and suicide. So we tried to capture where the field was at in a paper in the journal that Mario edits, World Psychiatry, last year, and tried to show that the research on this at-risk mental state, this ultra-high risk or clinical high-risk state, with its kind of non-specificity in a way, is a pathway. It's a prototype and a pathway to a more transdiagnostic staging approach in psychiatry. If you try to stage each of the traditional DSM disorders, it won't get anywhere because they're not valid in the same way. We have to have a transdiagnostic approach for this area of study. This is a follow-up study on 416 ultra-high risk patients who were followed up over a period of up to 14 years in our service in Melbourne. And what we found was there was a very significant comorbidity, new incidence of mood disorders, persistence of mood disorders, with only 7% of the patients not being diagnosable over the follow-up period with some form of DSM disorder. And the transition to psychosis rate was about 35% overall. So that wasn't even the majority of the patients. So this kind of broad transdiagnostic outcome is the point here. So while we originally started off thinking like this in a staging sense, using the staging idea from general medicine, we were trying to target one particular outcome by defining a risk state for that outcome. What we ended up finding was something much more like this, that there were multiple exit points, often with comorbidity themselves, and the early stages were really what we call microphenotypes. Not, if we think of schizophrenia or psychosis as a macrophenotype, a more stable syndrome, these early stages that we see in the headspace clinics, which I'll tell you about in a minute, in the early stages of illness, they're much more fluid and they're more like microphenotypes. And when they gel and come together as more stable syndromes, that's when we seem to recognize what we see in the DSM and the ICD. And it's fluid, as Mario alluded to. So we started to think of this broader concept, which Peter Jones's paper is about too, of a more pluripotent at-risk mental state. Some people call this within common mental disorders. I don't really like the term common mental disorders because it's segregating one set of psychopathology off from the rest without much real validity, apart from just prevalence. But anyway, we know that these subthreshold positive symptoms of psychosis are quite common in people with anxiety and depression, and some of them then go on to progress. But if you think of the pathway heading to multiple severe or disabling psychiatric syndromes, then this is the hypothesis. Like different flavors of ice cream. So one study that we're looking at over the last few years is called the CHARMS study, where we've recruited a cohort of patients who were not just diagnosed at risk for psychosis, but they also had subthreshold features of bipolar, depression, or borderline personality. Thinking of borderline more as a Axis 1 type syndrome than an Axis 2 syndrome. And these are operationally defined. I won't go through them all, but they were carefully defined. And the exit point to stage 2, or a full syndrome, a full threshold syndrome, was also carefully defined using operational criteria. So in other words, we're trying to do what Pim Kuiper suggested, that by having several lower prevalence outcomes as the exit syndrome, we might have a higher yield of transition for more severe mental disorders. But so we've got more inputs and we're looking to measure more outputs. So patients were described as either CHARMS positive or CHARMS negative. CHARMS negative were just people with anxiety and depression or stress, distress. CHARMS B had some more specific but still microphenotype level symptoms. And it did indeed, increase the transition rate. So it went as high as 40% by the end of the first year if you met one or more of these criteria. And they did overlap, and there were heterotypic transitions as well as homotypic transitions in the data too. I haven't got time to go into all that, but the most prevalent outcome was obviously depressions, more severe depression, because that's the more prevalent condition that we see in these young people. But there were some transitions to other, somewhat less common, and the sample is still only 200, so it's not a really huge sample yet. So it's a sort of a work in progress. It's broadening the focus. We're looking at predictors of transition. There's considerable overlap in these states and fluidity. There's heterotypic development as well as homotypic. And yeah, we're just looking at other aspects of that. Now, Ian Hickey, our colleague in Sydney, who we collaborate a lot on this staging idea, has just published a paper in JAMA Psychiatry, which shows that the transitions from 1A to 1B are very high, something like 36%, so from distress to a more worrying sort of risk-enriched level, and they don't subdivide them into these different diagnostic streams. And the transition rate from the 1B to 2 is a bit lower actually, but this is in about 2,000 patients. So this is getting a pretty good sample size and mapping this early trajectory and course. And again, it's fluid, and again, transition or progression is not inevitable. Many of these patients get better. They actually resolve and remit, just like early forms of cancer will do so if they're treated effectively. So this is the model we're trying to apply. So early intervention, as Mario said, you wouldn't have to actually start a journal in any other area of medicine just on early intervention, because they already know that it's a valuable thing. But in psychiatry, we've had to argue against our colleagues for a couple of decades about this, that it could be done. Some people still don't believe that it can actually be done, or that it's even worth doing. We're having a rebuttal a month in our local Australian Journal of Psychiatry with people who don't believe that this is working, despite all the evidence that has accumulated. So anyway, the purpose of starting the journal was to broaden the focus from psychosis into the other domains of psychiatry, because there was very little actually being done in any other area apart from psychosis until the last decade or so. Hopefully we'll be able to close the journal down very soon. And one of the things that was interesting about describing or trying to apply the staging model in psychiatry, which was originally an Italian idea actually, Giovanni Fava first coined the term, I think it must be about 30 years ago, or 25 years ago, just for anxiety, I think it was, or maybe for depression. But I think the data that we developed in psychosis and the fact that we wanted to extend it across all diagnoses was the big change, really. And so obviously trying to debate this, some of our colleagues want to develop a staging model for bipolar, another group want one for eating disorders, another group want it for depression, but that's missing the point. It has to be, when you look at the way disorders emerge for the first time, they come out of this primordial soup, if you want to put it that way, this undifferentiated sort of group of symptoms, which eventually sort of make a bit more sense in terms of DSM, but not at the beginning. Now, Mario also mentioned Tom's and NIMH's work in trying to break down the silos from a research point of view, to free up research. So you didn't just get the schizophreniologists in their conference and the bipolarists in their conference all doing the same work without realizing what the others were doing, basically trying to integrate the research strategies across the diagnostic silos. But it really wasn't designed for clinical utility. And another strategy which we're very interested in too is this high-top group, which have used quantitative psychology really to kind of look at the structure of psychopathology in people. And Mario's published a lot of papers on this in World Psychiatry as well. Very interesting. It's a scientific approach to the intrinsic nature of and relationships of symptoms to each other. But again, this has got very little clinical utility so far. And it doesn't have a temporal, come back to Tom's comment about the longitudinal course, it doesn't have a kind of a dynamic longitudinal element to it either. And is often looked at in chronic samples of patients. The P factor that you mentioned too, this is based from the same idea, that looking at the structure of psychopathology, and it looks like there is one large common factor that spans across, which also supports this idea of transdiagnosis. And there's other papers with very similar ideas. And there's been a debate happening in the journal. There was a kind of a negative paper published by Fusapoli, which really looked at treatment, transdiagnostic treatment, and was a critique. And it didn't look at these other staging and other ideas really. So there was a bit of a debate and dialogue in the wake of that paper, just in the latest issue actually, isn't it? So with Ian Hickey, who I just mentioned, we've published, just came out in August, a book on clinical staging, which has tried to capture the data and the concepts really behind what I've been talking about. So that's just appeared last month. And initially we had thought that it was like this. If you could define a risk syndrome, and it's like buying a ticket on a train. And if you bought that risk syndrome ticket, you would end up at the destination that it was predicting. But actually, the train lines got very crossed. So there were, you changed trains without realizing it, or you could end up at multiple stations at the same time. So the analogy really didn't work. The data didn't support this model, this kind of rigid model. I think I've mentioned all this. So that really sort of suggested that you can't develop a staging model for each individual disorder. And Jim van Os, I mentioned him, he's done, and people in the Netherlands have done a lot of very interesting work about how symptoms emerge, how they evolve. How do you become mentally ill? It doesn't just happen like that. It's a process. And I think Tom was talking about this. How do you sort of map the subjective onset of a disorder? And at what point do you cross the line for having a disorder? I guess the patient has a lot of say in deciding when that occurs. When is there a need for care? How do you define a need for care? But how does the sequence occur? And mapping this early stage, you need new technologies. Digital technologies are part of it, but also some of the ecological monitoring that has been developed in the Netherlands is capable of doing this too, also using technology. And it supports this sort of idea of the microphenotype. And this has now found its way into the Lancet Commission on Global Mental Health, which appeared last October. This is a model that has been endorsed within this publication, which it sort of makes sense as a support for early intervention. And there have been many papers, including other colleagues like Jan Scott and others, people from Canada, who've helped to, I suppose, introduce this idea into psychiatry. One of the techniques in research that helps us to get data for this is network analysis. And this was developed in the Netherlands with the idea that symptoms can be risk factors for each other. So if you start to sleep poorly, you may lose energy, and your mood might drop. You might get more worried and anxious and ruminating about things when you can't sleep, and that might actually produce a cascade of symptoms which lead eventually to a syndrome forming and you becoming more depressed. So, and he even postulates, that the founder of this technique, that the connection to biology is much looser than we really think. Now, you don't need to say that actually, but it's still a very interesting approach to mapping these onset phases. We did a follow-up study of 800 patients, presenting very early stages of mental ill health to our Headspace clinics, and found that the pattern changed over the first 12 months, and it changed in different ways depending on whether or not the patient progressed to a more stable syndrome or not. So the relationship of the symptoms, we didn't have enough data points to show exactly how that occurred, but that's what we're working on now, a more fine-grained analysis of this. And it could be supported by technology too. The changes were different in progressors and non-progressors, the relationship between the symptoms. And this is an idea of what it looks like over time. I don't know if the video will work. No, sorry, it didn't actually work. But this is a dynamic representation of how the symptom relationships do change over time. So this shows that instead of static models where we get baseline data and we predict what happens 12 months later, the situation is much more dynamic than this, and there are other areas of expertise that we can bring to bear on this. Sort of predictive models that are used in the stock exchange or in climate can be applied to this sort of data if we get enough good quality data. And one of the pioneers of this work has been Marika Vickers in the Netherlands as well. There's also possible common neurobiological substrates, not just common psychopathological patterns as well. And how to map biomarkers in this context? There's been a huge amount of effort, as Tom alluded to, in studying biomarkers in psychiatry, but most of it has been done through the lens of traditional diagnoses, and very little of it has been done by stage of illness. So if inflammation, for example, is a mechanism that's of interest in studying psychiatric disorders, why would it be limited to one particular disorder? Why wouldn't it be a more common thing across disorders? And why wouldn't it be a stage-related thing? Why wouldn't you have inflammation perhaps at the beginning of a disorder, which actually settles and is hard to measure later on? Or I guess these things could be the opposite way around too. The point being that the biomarkers might vary just as much by stages of illness as by syndrome. There's no reason particularly to assume why they would be more powerful in relation to a syndrome. But it's hard to really answer that question because the data's all being collected in a way that doesn't allow you to do it. And if we could actually define mechanisms of changing by stage like that, that would allow us to target treatments much more by stage than by syndrome. And that's the proposition. That's what we're trying to orientate our research around. So treatments can be transdiagnostic. And this is a study that the NIMH funded when Tom was director. So it's a CHR trial in emerging psychosis, but it's a SMART trial, so it's adapted to whether the patients respond or not, and it's a sequenced treatment trial, which again is probably a combination of stage and stepped care. And this is the more sophisticated sort of approach to the onset, the treatment of the onset of illnesses that we're trying to put in place. Okay, so the last part of my talk is about what has been mentioned already. How do we actually apply these ideas in the real world? What I've talked about so far is some of the conceptual thinking and some of the, I suppose, the intellectual basis for actually delivering early intervention in real people. And it has arisen in many ways out of the prototype of early intervention for psychosis, but it has also had to be adapted quite significantly to cover the full diagnostic range that we see. This is a paper describing that process. And it takes account of a very important observation, which actually Ron Kessler, sitting in the front row here, wrote the foreword, I think, for this book about age of onset of disorders. And it's very different from the age of onset for physical disorders. The onset of most mental disorders is in young people, some in children, like ADHD, the rest mainly in teenagers and young adults, or from puberty through to the mid-20s. And we know that the brain isn't maturing and it doesn't stop developing until the mid-20s, and that is actually borne out by the pattern of onset of most mental disorders, which really peak in the late teens, early 20s, most of them. So, could go into that in more detail, but mental illness is the #1 threat to young lives and futures in the world. It hasn't been treated that way, as Mario alluded to. It's been neglected, incredibly neglected. British psychiatrists described the neglect of adolescent mental health as a form of self-harm that society inflicts on itself. And now we're beginning to recognise this and address it. And so this is the real epidemiology, simplified, that you have a surge of incidents from sort of late in primary school, surging through, peaking in the mid-20s, and then desisting in the mid-20s. And if you don't get better, obviously the prevalence just accumulates across the lifespan. Physical illness has got the mirror image pattern of this, absolute mirror image. And yet our health system has been designed as if mental disorders had the same epidemiology as physical disorders. So very strong emphasis on little kids, very strong emphasis on middle-aged and older people. and the young people fall between the cracks. This is a great paper from JAMA Psychiatry by Moffat and Caspi, which showed that it's the same people, the people that get mental ill health in teenage and early adult life are the same people that are at a higher risk of medical disorders later in life. There's a higher risk of these things. Comorbidity. This is why people with psychiatric disorders die 15 to 20 years earlier than everybody else, because they're at risk for physical illnesses as well. And so it's a massive preventive opportunity that we have if we focus on young people's mental health. And they say, this is a great quote, psychiatry is well situated to prevent disability amongst older people by doing something it does well, treat young people. So that should be focus. I'll skip some of these in the interest of time, but this is, as well as the onset of disorder, it's an incredibly sensitive time developmentally for us as we move from childhood to adulthood. Huge developmental challenges and tasks, and often with very, very many other risk factors operating. So that's another reason for producing a different culture of care for these young people who are not necessarily going to trust. Tom used the word trust. What are the young people going to trust? They're not going to trust a service that's orientated around little kids, and they're certainly not going to trust a service where the average age of the patient is 45. So they're not going to engage in that. And technology is definitely part of the answer. It'd be a complementary and augmenting approach, as Tom pointed out. But you've also got to make the face-to-face and the experience, of mental health care or health care in general acceptable for them. And this is what this last bit is about. So in the last, I would say, 10 or 15 years, probably led in many places by people who were early psychosis people, but it's drawn in a much wider group now. These are the countries that have actually developed what we call integrated youth health care models, which is really a form of primary care, like an entry portal, developed and co-designed by young people with us as professionals, which creates a culture of care that is multidisciplinary and also oriented towards the needs of the young people in that stage of life. That's the goal. That's the goal. And these countries, I'll just show you very quickly where this has happened. So it's Australia. So this is a review in the Medical Journal of Australia of the global progress with this reform. So published in 2017. I can make that available if people are interested. And there's another paper in Lancet Psychiatry describing the same thing. So in Australia now, we developed in 2004 a model called Headspace, which was this integrated primary care clinic. It has GPs, allied health professionals, vocational support, and drug and alcohol. Those are the 4 features that it actually has, and youth participation as well. It started off with 10 centres. It's now in 110 locations across the country. In another 2 years, there will be 145 of these centres. So that is more or less full national coverage for this model. And in Denmark, where I'm going tomorrow, there are 30 of these Headspace centres. And Denmark was a country that introduced early psychosis services across the whole country too. So the Danes have been very progressive in this space. France has 104 centres called Maisons des Adolescents, which are same age group, 12 to 25. It's not this nonsense of having a boundary at 18 years where you're somehow an adult magically at 18 and you're forced to go into child and adolescent or adult services. These services are orientated towards 12 to 25, puberty to mid-20s. And these services have been in France for well over a decade and have the same idea. They're not quite as standardized and they're quite variable in terms of what they provide, but the idea is the same. Ireland has at least 15 jigsaw services. Canada has not national coverage, but pretty widespread coverage, especially in British Columbia, of these types of centres. And Israel was the second Headspace was opened in Israel just recently in Jerusalem, so it has 2 now. The Netherlands has a program called At Ease, which is the same concept. The UK has some centres, and in the US, I think Tom's associated with this. There's work out of Stanford, which is establishing 2 integrated youth health services called Alcove, I think it's called, in the north of California. Now just finally, just to step back a little bit from youth mental health and from the whole early intervention sort of infrastructure, mental health is starting to get a lot more traction in global terms. At the World Economic Forum in Davos, the World Economic Forum announced a new program of projects in this space. There's Prince William there in the middle, and I think it's the Prime Minister of New Zealand on the right, Jacinda Ardern. And we have a project within this on youth mental health. Origin, my organisation in Australia, we have a project which is producing a flexible version of this integrated healthcare model for young people, which can be flexed according to different resource settings, as well as a few other outcomes. So that's happening. There's been planning meetings in London and in New York for this. This is the New York meeting, just happened last week as part of the UN sort of festival of events. So there's really great buy-in from a whole range of players in this space now to develop this approach. And finally, the Lancet Psychiatry Journal has commissioned a special commission in youth mental health to kind of capture some of these practical reforms and the evidence supporting them. So as you can see, it's not just a question of doing research or providing clinical care. It's about designing and reforming a health system. And technology, I haven't talked about that, but that absolutely is a key pillar of this. It's actually creating something for the 21st century, not from the 19th century. Psychiatry has been stuck in the 19th century for a long time. This is bringing it into the 21st century. And Italy has tried to do that, as Tom mentioned, through Trieste. That was a stepping stone. These reforms are very hard. They're very hard. But the public are starting to realise it's in their own self-interest now to actually get behind these. And that's very hopeful, I think. And I think the last thing I'll say is there are a couple of important international platforms. The International Association for Youth Mental Health is having its 5th conference in Brisbane later this month. That's got a third of the audience is under 25 in this conference. It's very dynamic. And then we also have the IPA, which is the Early Intervention conference that's been going since the mid-90s. So these are platforms that bring like-minded collaborative leadership from all around the world together to drive these reforms. And Italy has been involved in this. That conference has been in Milan some years ago, and it's a very important movement to give hope and optimism to psychiatry, a sense of capacity to really tackle these huge challenges as we go forward.